My name's Anna. I live in Spain and I've had type 1 diabetes for 17 plus years. I was originally diagnosed in Argentina and then moved to Spain. And well, I'm in the association, the patient association in Madrid. I have no complications so far.
Hi, my name is Eric. I'm based in the Netherlands. I've lived with diabetes type 2 for 25 years. And I don't have CVD-related complications yet, but they run in my family, so I consider myself at high risk, especially in combination with my diabetes.
Hello, everyone. My name is Kostas Makrilakis. I'm a professor of internal medicine and metabolic diseases. I'm actively involved in diabetes since 2002. I work as a clinician, researcher and educator. I am currently serving for the third time as a board member of IDF Europe, and I'm also the General Secretary of the Hellenic Diabetes Association. I'm working in a diabetes clinic at the University Hospital, having an insulin pump clinic also, an obesity clinic, and a diabetes food clinic. And I'm very thrilled to be here.
I'm Tatiana Milenkovic. I'm professor of internal medicine at the University St. Cyril and Methodius in medical faculty in Skopje, Macedonia. For over 35 years, I'm working as an endocrinologist in our University Hospital for Endocrinology, Diabetes and Metabolic Disorders. And my main focus are patients with diabetes, patient education, and also treatment of diabetes of patients with diabetes type 1 and type 2 as well. Also, I'm the part of IDF Europe board for a second time. I'm a president of Macedonian Diabetes Association, and also I'm president of Scientific Association of Endocrinologists and Diabetologists of Macedonia. And I can start maybe today's discussion. So I'm really thrilled to be here today on a World Heart Day to discuss about cardiovascular diseases and diabetes. So I will first ask my dear colleague Kostas to provide us with more information on what links cardiovascular diseases and diabetes.
Yeah, thank you, Tatiana. Today, diabetes is a very prevalent, very frequent disease. 61 million people live with diabetes in Europe, and out of them, 32 million people are in the European Union countries, and 60 million people live with cardiovascular disease in the European Union. So that's a huge number of people suffering from both diseases. And 1 in 10 people with diabetes are not aware of cardiovascular disease and its risk factors. Diabetes is a very significant risk factor for cardiovascular disease, and people with diabetes are 2 times more likely to get cardiovascular disease, which is the leading cause of death. Diabetes and CVD are linked in many ways. They have a lot of common issues, and so that's why it's both of them are coexistent in many people, and they are very prevalent. And unfortunately, many people do not know about these things. So I would like to ask Eric and Anna Maria, when did you become aware of diabetes as a CVD risk factor?
Thank you, Kostas. Well, during my treatment, cardiovascular disease was sometimes mentioned as a risk factor. However, it was only one of the risk factors mentioned, and details and information about severity of this risk factor were not shared with me. In fact, type 2 healthcare professionals that I encountered most of the time don't mention it. Their focus is more on acting on lab results instead of trying to help me in reducing the risk factors that can occur on a longer term. During my voluntary work for the Dutch Diabetes Fund, evaluating research projects, I became more aware about CVD as a risk factor and also what the impact was on people with type 2 and type 1 diabetes. Well, many of the persons with diabetes I know are not very aware of the severity of this risk factor. I think education there lacks and is not sufficient.
I agree with you, Eric, definitely. I remember when I was first diagnosed, there was a long list of potential complications, and cardiovascular disease was one of them, which was terribly scary. At that time, I have slight genetic predisposition to heart conditions. And it was really, really scary. But the whole scare tactic worked at the time. I was paralyzed. This is awful. Diabetes can cause so many different things. I'm going to die of a heart attack. That's what I thought at the time. I have 2 young kids. I need to address this. But that was it. There was no education and no information on preventing CVDs from developing and from keeping all the risk factors in check. All I remember is keep your cholesterol in check and don't smoke. And that was it. That was my history and Eric's. Tatiana, do you see awareness? Is there a certain level of awareness of the risk involved and how diabetes may contribute to CVDs in the people with diabetes you see on a daily basis?
Most of them are not sufficiently aware of this risk and actually what are the specific parts of that risk and practically what it means for them. So it is very important to emphasize that the risk for cardiovascular diseases to a certain degree is different in patients with type 1 and in those with type 2 diabetes. So for type 1 diabetes, blood glucose control assessed by hemoglobin A1C is generally considered as a most powerful risk factor for cardiovascular diseases. Absolutely with other traditional risk factors like blood pressure, LDL cholesterol, especially after 15 to 20 years after onset of type 1 diabetes. But although the people with type 1 are in good control, still the risk for cardiovascular diseases stays high. And this actually is suggesting that there are some additional risks like glucose variability, then hypoglycemia, abnormalities of different lipoproteins also are involved in this risk, and mainly chronic kidney disease is one of the most important risk for cardiovascular diseases in patients with type 1 diabetes. Actually, in the presence of diabetes nephropathy, then dramatically increases the risk for coronary heart disease in patients with type 1 diabetes. In those with type 2 diabetes, risks are in general within the metabolic syndrome. It means insulin resistance, abdominal obesity, then atherogenic dyslipidemia, mainly increased triglycerides, low HDL cholesterol, high LDL cholesterol, then high blood pressure, of course, prothrombotic, pro-inflammatory, and the oxidative stress state that diabetes is by itself, and of course, chronic kidney disease and non-alcoholic fatty liver disease are also the strong risk factors for cardiovascular diseases in patients with diabetes. So there are a bit slight differences, so that we can address a different maybe even strategy in prevention of cardiovascular diseases in people with type 1 and type 2 diabetes.
As Tatiana said, people with diabetes are at high risk of developing heart-related complications, but fortunately, there are several strategies that these people can implement to reduce their risk. Prevention is very key to prevent all these complications that might develop in people with diabetes. So I think if they do all these things, control their blood sugar, their blood pressure, their cholesterol, quit smoking, try and lose weight if they are obese, adhere to their medication, they will not develop cardiovascular disease, or at least they will delay it for many years, which gives them a good quality of life.
Right, very interesting. But let's say we do our best, we do things by the book, weight management, cholesterol in check, blood pressure in range, blood sugars in range, etc., no smoking, and still develop CVDs. How do you best manage a CVD after its onset?
Everything that we said before for treating diabetes are nearly the same now, but they are even more important because if CVD has developed already, it is very important that they learn what diabetes does to them and what CVD does to them, and they try to avoid all these risk factors. I don't know if Tatiana, you want to add something to these things?
I will add something. We are working in a multidisciplinary team, and I'm very often faced with questions from my colleagues, cardiologists and nephrologists. And the first question is, why are you so focused on glycemia? So this is really misconception about our work, because we as an endocrinologist really focus on a comprehensive approach to managing diabetes. This means that we addresses the dyslipidemia, hypertension, obesity, other cardiovascular risk factors, habits, smoking, dieting, and also glucose. So from a cardiologist point of view, they only tend to see the heart in the patient of diabetes, which is inappropriate because in managing these complex conditions, we cannot disregard eyes, kidney, even leg amputation. So our recommendations are very clear in this sense that the treatment should be individualized, focused on comorbidities of each patient, and control of all risk factors for cardiovascular diseases. How do you choose to manage your cardiovascular disease risk?
Well, as Anna already mentioned earlier in this discussion, there's a huge list of scary potential complications that patients with diabetes have to deal with. You can't deal with them separately. For me, lifestyle choices in combination with glucose management and regular blood pressure checks is the way I manage my diabetes on a daily basis. I manage it as a whole, and CVD risk is part of that. And using CGM allows me to act properly on blood glucose levels, and a low-carb, mostly vegetarian and balanced diet in combination with regular exercise is part of my lifestyle. It keeps me healthy and it reduces the risk of complications, not only CVD. Anna, I'm wondering, is your management of CVD risk different?
Well, Eric, I would say it's basically the same. Blood sugar management, first and foremost, because it's kind of what comes first to mind and what we are taught to focus on. Blood pressure, lowering cholesterol, eating healthy, doing exercise, which I'm not very good at, but I do lots of walking, and I'm lazy. I don't like it, but I do. I know it's important, so I make a point of doing that. I quit smoking shortly after my diagnosis, and it was really the toughest change I had to make. Changes in diet were okay. I was already a vegetarian, so I stayed that way. But basically, it's the same. It's what we are told to do, and we try to do it. So this is how we address the risks. But what would you say are the biggest challenges in managing established cardiovascular disease? And how do we overcome these challenges?
I think most of persons with diabetes are not very aware of potential future complications. And the word future is the important factor. They just want to live and they don't want to change their lifestyle and do things that don't fit in the way they think they should live. So CVD risk is not seen as a big risk. It's far away. And I think more awareness and education is required to be able to minimize this risk. And healthcare professionals that I encountered are often focused on treating ADH1C levels, cholesterol, kidney function, just the basic things. And they don't address the future risks. Well, they do that by means of controlling those values, but what is missing is the education and information and trying to help people with diabetes in changing their lifestyle and making diabetes part of their life reducing those risks. So for me, that's the thing that's greatly missing there.
Oh, Eric, I agree with your comment, because the people with diabetes need really education about different aspects of their disease, but mostly on cardiovascular diseases and risks. And such education and involvement of people with diabetes in the treatment is very important. So people with diabetes actually should know the goals of the treatment, and they should be actively involved in that, how to reach and maintain these goals in a long run to reduce their cardiovascular risk. Also, sometimes it's not enough just to involve the patient, but it is important to involve the whole family into this process, because the family can be a very good support in terms of introducing a healthy diet for all family or physical activity, and that can reduce the risk. But in order to achieve this level of education for people of diabetes, we really need a multidisciplinary team, a trained team, which consists of diabetes educators, mainly nurses, then psychologists, dietitians, and many different kinds of specialities of different doctors involved. So in one word, in people with diabetes, they need integrated and really patient-centered care. The care, what is the most important and relevant for the patient and the specific stage of their diabetes.
I really agree with that. And having a multidisciplinary team and having quality time with your physician. But the problem is time. The time in the doctor's office is limited. It's restricted. The system makes it difficult for a broader education system to be provided to patients. In most of our countries, it is hard. And I would say that this is where patient associations play an important role, because they can supplement and complement the education provided the doctor's office, the nurse at the hospital, or whatever the system is. We have patient associations and we have peer support groups. We can have a great source of support, a source of education. Quite often what we find is that people leave the doctor's office with more questions than answers, and they have to wait 3-6 months to voice their concerns again. So talking to peers or going to your association can help, and they can also provide guidance on, okay, you need to get another consult, go to the doctors again. You can read this, but please ask your doctor. And I think that's the value of working together.
Yeah, I agree completely with what Anna said. Time devoted to people with diabetes is one of the most important things that physicians need to devote to them, to give them all the information they need. The problem is most physicians do not have that time, and also the amount of information that they have to give to the patients is so big that the patients are not able to swallow all this information in one bout. So you need to have repeated sessions and go step by step to teach them. And here the primary care physicians play a very, very significant role. We need the primary care, integrated care with the patient-centered care for improving the management of diabetes. Because as Eric implied earlier, people with diabetes should have a holistic management. It's not only blood sugar. You need to treat the person, not only just a blood level. All these resources that are available today with the internet and all the support groups that exist, they might not be accessible to all people. And there's a great variety in the various countries, even in Europe, even inside the country. We have a great heterogeneity of treatment, depending on where people live and their education level and so forth. I agree that strengthening primary care and integrated care and patient-centered care is essential for optimizing diabetes management. And these approaches not only improve the quality of care, but they also enhance the overall well-being of individuals with diabetes, and they reduce healthcare costs, because if you treat people well, they don't get complications, and so you contribute to better health outcomes for the community also. And here comes the innovation and the help from digitalization of our society today, because we have today a lot of help from technology. Eric mentioned CGM, glucose continuous monitoring devices that can help them monitor the blood glucose in real time. So it's very, very important that people have access to all these technological devices. Like today, we have a lot of mobile applications and health tracking platforms that people can register with. A lot of them are free, and they can monitor their blood glucose levels. They can monitor their exercise, their food intake, even their medications. They can have messages sent to them to remind them of taking their medications. Today, we have smart pens that remind people how many units of insulin they took, and if they missed doses, they remind them. So technology is coming to help. But of course, education and support is also something that we have to strive with, because there's so much variety. So in conclusion, I think the digital innovations have the potential to really revolutionize diabetes management and bring prevention closer to us by offering all these tools for continuing monitoring and having a personalized care, because you can adapt everything to the person and give a different treatment to different people.
Yeah, you're so right, Kostas, because I don't even know how I was able to manage my blood glucose levels before I had the CGM. I couldn't do it without anymore. And prevention is better than curing. So that means that you need the means to be able to prevent it, to manage your blood sugar levels. And treatment should start as early as possible with personalized care, including education and self-management supported by technology. And regular checkups and good screening could help in early diagnosis of CVD and timely treatment. And I also think that periodical screening would also increase awareness about the severity of CVD. We are not doing it for nothing, that it is something that needs to be dealt with. But Kostas, what do you think is necessary to ensure effective and timely screening of persons with diabetes?
Yeah, this is a very crucial thing, because if you screen people for CVD, you might be able to prevent it. Now here, the guidelines from the professional organizations are not always very clear, because they need to be based on evidence, and the evidence is not always there. So the risk assessment is very crucial. And so we need to implement regular monitoring schedules for CVD risk factors on people, so they can have a regular measurement of their blood pressure and their cholesterol profile and their blood sugar. People with diabetes should be empowered, and they should be taught to recognize the risk factors, to monitor them, and proactively ask for advice if they are not good. I think what is necessary to ensure this effective and timely screening is education to people to monitor their risk factors. It's not to do stress tests and angiograms. It's to attack the risk factors. This is the most important thing, I think.
Well, prevention in changing lifestyles and checking for risk factors. What about medication? What about medication that has cardiorenal features? Type 1s don't usually get them. I think it's mainly because they have not been tested. There have not been enough trials on efficacy and side effects for type 1s. And when we get SGLT2s or GLPs or whatever, it's off-label. And it depends on fears and experience of clinicians and not on clinical guidelines. Is this correct? Or is it just my I don't know, Tatiana, can you help me?
I will try to answer. So the both groups of drugs, GLP-1s and SGLT2 inhibitors, they are examined on many clinical trials in people with type 1 diabetes, and mainly they shows a quite beneficial effect in these patients. But why they are still off-label treatment, it is because some safety issues, especially hypoglycemic reaction with GLP-1s in type 1 diabetes, and then normoglycemic ketoacidosis in CGLT2s when we are using them in type 1 diabetes. So I think so that if there is a careful patient selection and monitoring, and also the doctor's experience to minimize side effects and to maximize benefits of these drugs, especially because they are off-label, they can be used without precautions in type 1 diabetes. I think so that we will have there some improvements in the future, because there are there are great potential in these two groups of drugs to treat also people with type 1 diabetes in the future.
Right.
So I think this is a very interesting point that has been brought up here, and all these complications that we're talking about, we refer to people. So we need to inform them, to educate them, but we should not really scare them, right? We should talk to them how to avoid the complications. But I would like to ask first Anna Maria and then Eric, what do you think is this issue of increasing awareness of CVD risk without scaring people? How should we do it?
I think that's a tough question, and it puts a lot of the burden is on the clinician, on knowing their patients, being aware of what their limitations are. Some people want to know everything and every single gory detail of whatever might happen, and some people don't want to know anything at all. They don't want to find out what can happen, and it has to do with personality. So if a clinician can read a patient well, they know how far they can go with information, and that's really tough. So I don't think there are any hard and fast rules. I think scare tactics don't work, and it probably has to be a gradual process, especially if it's a new patient. But we do need to make people aware of CVD risk and how to address it. I don't know, it's a multidisciplinary approach, and still a long way to walk. I don't know, Eric, what do you think?
Yeah, I can only say that I agree with you. No person is the same, and likewise, no person with diabetes is the same, and everyone consumes the information in another way. And that means that a differentiated approach is necessary in increasing awareness of CVD risk. People with diabetes already have to manage a very complex condition. So it's really a challenge for healthcare professionals to find a way that is the best in individual persons to help them in managing their condition. Awareness is a skill. It's difficult, and you can't do it in one way, not in CVD or not in any other area.
Yeah, I agree. It's tough, and it's so varied. But I mean, there are some common things that should be done on all people. First of all, the physician should be supportive and empathetic to people. They should express their empathy and understanding for the challenges and concerns that people with diabetes face. They should use plain language. They should not use like medical jargon that people do not understand. And this will help prevent confusion, because sometimes physicians talk in a medical way and people are ashamed to ask, what do you mean? And they do not understand. And that's the end of the educational conversation. Go slowly and shift the focus from fear to empowerment. You have to give them positive stories, like success stories from other people, and highlight things that were done correctly to other people so they can probably do the same. Building a good relationship between the doctor and the physician is critical. If he trusts you and you trust that he will follow your advice, then things will get better. And of course, you have to set realistic goals. I mean, you cannot ask people to do things that they are not going to do just because the guidelines say it. You have to see what he wants to, what the person wants to do and can do. If it's not achievable, it's not going to be done. So small, manageable steps is the way to go.
Yes, absolutely. I agree with all three of you, because the approach to the patient should not be intimidating, but with explanation what are the risks and how the patient with his doctor can minimize these risks. So the doctors or healthcare professionals, they must show empathy, but at the same time, they must send a clear message and to encourage their patients to make appropriate lifestyle changes that will reduce the risk of complications. And for that, we need to have an informed patient. So this discussion is mainly about it. The patients must be informed about their risk and the ways, together with the healthcare team, how to minimize this risk of cardiovascular diseases.
And for me, it would help me if healthcare professionals will be a partner and they have their expertise and they have the information that I need. And if you get a good relationship together, then you can partner up and manage your diabetes as patient with diabetes.
So I think we are coming to an end of this interesting conversation. I hope we have given some messages to people. Maybe we should ask everyone to give a final message. Let's start with our people with diabetes. Anna Marie and Eric, what do you think a final message would be from this conversation that we had today?
I would say that as a person with diabetes, you have to ask questions. And if you don't understand the answers, you have to ask again and try to educate yourself, get information, know what you're facing, and don't be afraid, because if you're afraid, you're going to not be able to function properly. But ask and ask again. And share with peers, because a disease like diabetes and its complications as CVD will make you feel lonely and isolated, but you're not alone. So share with your doctor, share with your nurse and your educator and your friends and your peers, and get support, empower yourself, educate yourself.
I agree. That's important. And from healthcare perspective, I would like to add that if people with diabetes don't ask the questions, then help them in finding those questions and ask them, give them that information. Be a partner for a person with diabetes, and together we may be able to manage the disease and prevent complications.
Tatiana?
So absolutely agree, Eric. We must building patients' knowledge on diabetes and cardiovascular diseases, even in those who are not asking, because sometimes the people who don't know the risk cannot ask the proper questions. So we should start the discussion. Even healthcare professionals must be educated better to know how to share their knowledge with their patients.
Yeah, of course, I agree with everyone. I think today we have the means to help people, but there are individual problems always. One of the problems, as already mentioned, is the time that can be devoted to people. And this is not always the fault of the physicians, because they are not given time by the healthcare organizations. So this is something that together physicians and patients should ask for more time to be together, because by having discussions between the physicians and the people with diabetes, you can really improve fear and anxiety they have because they learn things. So it is very essential to foster a sense of partnership between physicians and people with diabetes, and this needs time. So if you're not given this time, this will not promote the overall well-being of the patients.